This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome to the Deep Dive. Today we are getting into some really demanding territory in gastroenterology advanced endoscopy.
We'll touch on everything from, the physical well-being of the clinician doing the procedure, right through to managing high-risk complications in, say, specialized patient groups. Technical skill is obviously vital, but it has to be built on a solid foundation of safety.
And maybe we should start where we often overlook things, the actual physical toll of doing this kind of demanding work. Let's jump right into endoscopist safety, starting with ergonomics.
Yeah, when we talk about advanced endoscopy, you might picture really fine, precise movements with the scope. But the reality, it's incredibly physically taxing, almost like being an athlete in some ways. The sources we looked at highlight something called endoscopy-related injury, ERI, and honestly, the statistics are, they're pretty alarming.
Alarming is putting it mildly. We're talking about a majority of doctors doing this work being affected. ERI prevalence is cited as anywhere from 39% up to 89% of practicing GIs. And it's not just experienced folks. 20 to 47% of trainees are reporting injuries too. That really tells you this is baked into the system, doesn't it? Not just wear and tear over time.
Oh, absolutely. It's structural. And these aren't minor icks. We're talking about injuries that can limit careers, needing time off, physio, sometimes chronic pain management. So what's driving it? Well, the sources point to a few things piling up. Increasing obesity rates, which makes just positioning patients harder, longer working hours, higher procedure volumes, and maybe most importantly, the increasing complexity of the procedures themselves. Think ESD, complex ERCPs.
Right. It's that cumulative effect. Non-neutral posture, repetitive movements, hour after hour. So where do these injuries actually show up? What parts of the body?
Pretty much the whole upper body and lower back, too. We see pain in hands, wrists, elbows, shoulders, neck, back, even legs. And they identify specific conditions. For instance, Dacre-Vein's syndrome that comes directly from all the repetitive thumb bending and extending you do, manipulating the scope controls. And of course, carpal tunnel syndrome is a constant risk, given wrist positioning and pressure.
Okay, so if these injuries are sort of inherent to the job right now, what are the practical, evidence-based ways to make the workflow better? It sounds like we need actual structured changes, not just telling people to remember to stretch occasionally.
That structure really needs to start before the procedure even begins with what's called the ergonomic timeout. It's just a quick formal check, reminds the endoscopist to get into a neutral body position, check the bed height, make sure the monitor is at eye level, adjust the foot pedal. Just maintaining that neutral posture cuts down muscle effort and helps with endurance through the day.
What about the tools themselves? The equipment? Can that contribute?
Oh, definitely. If the angulation wheels on the scope are stiff, that massively increases the strain on your thumb and hand. If a scope feels stiff, it needs servicing, period. Simple things can help too, like using dial adapters for those wheels. And I like the detail in the sources about specialized flooring. They actually recommend cushioned mats, about 38 to 58 of an inch thick.
Cushioned mats? Why? Just for comfort. Seems a bit basic.
It sounds basic, but it's quite clever, actually. It's not just comfort. The mat creates a tiny bit of postural instability. You don't really notice it, but it forces you to make constant small shifts in your position. That keeps blood circulating better, reduces static muscle fatigue, and stops you putting sustained pressure on the same joints for too long.
Smart. And finally, managing the workload itself. How do they suggest breaking up these long, intense scoping sessions?
Two main things. First, targeted stretching micro breaks. Just 1 or 2 minutes during a long case or between procedures. Simple stretches for the neck, back, hands. Second, and this is maybe more structural, managing the schedule. Thinking about split days, maybe endoscopy in the morning, clinic work in the afternoon, or making sure there are rest days scheduled between full-on endoscopy days to allow for some recovery. This is all about making the career sustainable.
Okay, so that covers the long-term physical health of the doctor. Let's switch gears to the immediate safety protocols, the ones protecting both the physician and the patient during procedures that use fluoroscopy, like ERCP. And that brings us straight to the core principle, ALARA.
Right, ALARA. It stands for as low as reasonably achievable. It's really the guiding philosophy for all radiation use in medicine. And practically it boils down to 3 main strategies. Minimize your exposure time, maximize your distance from the source, and use appropriate shielding.
Let's break those down. How do you minimize time effectively without, rushing the procedure or compromising the goal?
It's really about being efficient with when the X-ray beam is actually on. Use less fluoroscopy overall. Avoid taking multiple pictures of the same thing, cut down on redundant views, limit spot films unless they're really necessary. The key technical trick here is using pulsed X-ray mode instead of continuous fluoroscopy. It gives you these short bursts of radiation, which dramatically cuts the total dose while usually still giving you a good enough image.
Okay, pulsed mode. Got it. Now, maximizing distance. This relies on the inverse square law, right? What does that mean practically for someone standing next to the C-arm?
The inverse square law is incredibly powerful. Basically, if you double your distance from the radiation source, and remember, the patient is the main source of scatter radiation, you decrease your exposure by a factor of 4. So even small increases in distance make a big difference. You want to position the X-ray tube as far from the patient and staff as you reasonably can. The guideline says at least 30 centimeters. And you also want the image receptor, the detective part, as close to the patient as possible. Minimizing that air gap cuts down scatter.
And thinking about shielding and where you actually stand, where's the safest place for the endoscopist to be relative to the X-ray beam?
Okay, this is crucial. Since the patient is scattering the radiation, you want to stand on the image receptor side of the patient, not the side where the X-ray tube, the generator, is located. Standing on the receptor side means the patient's body and the receptor itself block some of the direct scatter coming towards you.
Makes sense. And what about personal shielding? What absolutely needs to be worn?
Well, beyond the fixed shielding in the room, like LED screens, everyone directly involved needs personal protective gear. Two-piece lead aprons are generally recommended because they shift the weight onto your hips, which is easier on your back than the old single-piece ones. A thyroid shield is absolutely mandatory. And, something often overlooked, protective lead glass eyewear. You need that to prevent radiation-induced cataracts, which is a real long-term risk from scatter hitting the lens of the eye. And, of course, personal dosimeters to track your cumulative dose.
All right, so we've covered those fundamental safety layers for the clinician.
Yeah.
Now let's apply that safety thinking to some more complex patient situations, starting with one of the highest stakes scenarios, doing endoscopy during pregnancy. Hashtag endoscopy in pregnancy.
Yeah, doing any endoscopy in a pregnant patient is really something you only do if absolutely necessary. There has to be a clear, compelling reason, think the severe, life-threatening cholangitis, or maybe uncontrollable GI bleeding. And it needs incredibly detailed, informed consent, obviously. If you can put it off, you should. The strong preference is always to wait until the second, or ideally, the third trimester if possible.
And fetal monitoring, is that always required?
It becomes mandatory after 24 weeks of gestation. Before that, it's often done, but after 24 weeks, yes. You'll typically have obstetrics involved, often anesthesia too, to make sure both mother and baby are continuously monitored. That frees up the endoscopist to focus completely on doing the procedure as quickly and safely as possible.
Let's focus specifically on ERCP in pregnancy, because that involves fluoroscopy.
Yeah.
What are the absolute must-dos regarding positioning and setup?
Okay, first rule. Avoid having the patient lie flat on their back, especially later in pregnancy. That compresses the vena cava. The left lateral position is much better in the second or third trimester. If you absolutely must proceed with ERCP, you need that diagnosis confirmed first, ideally with ultrasound or MRCP, before you expose the patient and fetus to radiation for a therapeutic procedure.
And the radiation shielding, it's a bit counterintuitive, isn't it?
Yeah.
Where does the lead actually go?
Yes, this is a critical point that people can get wrong, because the C-arm usually shoots the X-ray beam from underneath the table upwards through the patient. The lead apron or shielding mat has to be placed underneath the patient's lower abdomen, directly between the X-ray source and the fetus. Putting it on top of the patient's belly does absolutely nothing to block the primary beam path in that setup.
Okay, underneath, got it. And therapeutically, the goal isn't necessarily a complete fix right then and there.
No, absolutely not. The sources are very clear. Avoid complex, lengthy interventions like trying to clear out every single stone. The goal is simply urgent relief drainage. Typically, that means placing a large plastic biliary stent, maybe 10 French or even larger, to ensure the bile flows, and then scheduling the definitive stone clearance ERCP for after the baby is delivered.
Right. And one last technical point, using electrocautery for sphincterotomy.
Yeah.
Why is the placement of that return electrode pad so specific in pregnancy?
It's all about minimizing the path of the electrical current. You want to avoid having the current flow through the amniotic fluid, if at all possible. So while sphincterotomy is considered safe, the return electrode pad, the sticky pad, must be placed on the patient's back, but above the diaphragm. So think like the right shoulder blade area. That keeps the current pathway well away from the uterus and the fetus. Hashtag capsule endoscopy and retention management.
Okay, moving away from invasive procedures to something less invasive.
Uh.
Capsule endoscopy. Amazing technology for seeing the small bowel. What are the main reasons you'd reach for this?
Yeah, it's incredibly useful. The main indications are looking for a source of obscure GI bleeding after negative scopes top and bottom, investigating iron deficiency anemia when the EGD and colonoscopy don't show anything, evaluating for suspected Crohn's disease in the small bowel, and sometimes looking for small bowel tumors.
But the big worry with anything going to the small bowel is it might get stuck. How often does capsule retention actually happen, and how is it defined?
Right, retention is the main risk. It's formally defined as the capsule staying inside the GI tract for at least 2 weeks. The overall risk is pretty low for most indications, maybe 1.5% for obscure GI bleeding. But, and this is important, that risk jumps up significantly to around 5% if the patient has known Crohn's disease or even suspected Crohn's, or if they're a heavy NSAID user, because those things can cause strictures, narrowing in the bowel.
So if you suspect a patient might have a narrowing, how do you check first before sending down the expensive camera capsule?
You use what's called a patency capsule. It's basically a test capsule that's designed to dissolve if it gets held up for too long. If the patient passes this patency capsule intact in their stool, or if imaging shows it's moved into the colon after about 30 hours, then you know the small bowel is patent open enough for the real capsule. However, if the patency capsule disintegrates before passing, that tells you there probably is a significant stricture, and it's not safe to use the diagnostic video capsule.
Okay. And let's say, despite precautions, the video capsule does get retained. What are the options then?
Well, it depends a bit on why it's retained and if the patient has symptoms. If it's stuck behind an inflammatory stricture, say from Crohn's, you might try medical therapy first, stop NSAIDs, maybe use steroids or anti-TNF drugs to reduce the inflammation and hopefully let it pass. If that doesn't work, or if it's stuck for another reason, you might need to retrieve it. Options include deep enteroscopy using specialized long scopes like balloon-assisted enteroscopy, or, especially if it seems to be stuck behind a potential mass or tumor, surgery might be necessary to remove both the capsule and the blockage.
All right, let's transition now to really the workhorse of advanced therapeutic endoscopy, ERCP. The sources make a strong point that its role has really shifted over the years. Hashtag the evolving role of ERCP.
Yeah, that's definitely true. ERCP used to be used a lot more for just diagnosis, but now with the quality of MRCP in the US, its role is overwhelmingly therapeutic. We use it mainly for treating problems like obstructive jaundice, getting rid of symptomatic gallstones from the bile duct or stones from the pancreatic duct, opening up strictures, sealing leaks, and sometimes treating sphincter of Oddi dysfunction.
And this shift towards being purely therapeutic brings up a really critical point of caution that the guidelines emphasize: when not to do an ERCP.
Absolutely. This is a key principle for safety. Just because imaging, say an ultrasound or CT, shows a dilated bile duct or pancreatal duct, if the patient is completely asymptomatic and their liver function tests are normal, that finding alone does not justify doing an ERCP. The potential risks of the procedure outweigh the benefits in that situation. You really need to investigate further with less invasive tests first, like MRCP or EUS, to confirm there's actually something that needs fixing before you commit to an ERCP. Hashtag understanding and mitigating adverse events.
And those risks are real. We need to keep the potential adverse events in mind. What's the sort of statistical picture?
Yeah, looking at large meta-analyses, the overall rate of adverse events isn't trivial. The most common and maybe most feared complication is post-ERCP pancreatitis, PEP. That happens in roughly 4.6% of procedures overall. Other significant risks include bleeding, usually after sphincterotomy, around 1.5%, infection or cholangitis, about 2.5%, and perforation, which is rare but serious, around 0.5%.
Okay, let's focus on PP post-ERCP pancreatitis. It's really the procedure's main downside. What makes a patient or the procedure itself higher risk for developing PP?
There are definitely known risk factors. Patient-related ones include having had PAP before, being female, having a suspected sphincter of Oddi dysfunction, and having a normal bilirubin level, maybe because the duct is harder to cannulate. Procedure-related risks are things like having a difficult cannulation, usually defined as taking longer than 6 minutes, or needing more than 6 attempts to get into the desired duct, and injecting contrast multiple times into the pancreatic duct. Interestingly, the sources point out that just doing a standard biliary sphincterotomy or extracting stones by themselves aren't actually independent risk factors for PP.
So if you identify a patient as being high risk based on those factors, what's the definitive evidence-backed strategy to prevent PP?
The first line of defense is pharmacological. It's using rectal nonsteroidal anti-inflammatory drugs, NSAIDs. Giving a 100 milligram suppository of either indomethacin or diclofenac, usually about 30 minutes before or sometimes during the ERCP, has been clearly shown to significantly reduce the risk of PP. It's pretty much standard practice now for most patients, certainly high-risk ones.
Right. NSAIDs first.
Yeah.
And the second major tool is mechanical, right? Prophylactic pancreatic stents. How well do they work and when are they indicated?
They work extremely well. Placing a small stent temporarily into the pancreatic duct is proven to decrease PP risk quite dramatically. The odds ratio is around 0.22, which is a huge protective effect. The number needed to treat, or NNT, is only 8, meaning you only need to place stents in 8 high-risk patients to prevent 1 case of PP.
Yeah.
So we use these small stents, usually 3 to 5 French in diameter, a few centimeters long in specific high-risk situations. Definitely if you have difficult cannulation, especially if you keep getting into the pancreatic duct, if you use the double guide wire technique, or if you perform a Loon dilation of the biliary sphincter when it was previously intact.
And I think it's worth highlighting the SVI trial here, because that really changed practice, didn't it? It wasn't just about if prevention works, but what combination is best for high-risk patients.
Absolutely. The SVI trial was a very important study. It was a randomized trial looking specifically at high-risk patients. It compared giving rectal indomethacin alone versus giving indomethacin plus placing a prophylactic pancreatic duct PB stent. And the key finding was that indomethacin alone was not as effective as the combination of indomethacin plus the stent in preventing PEP in these high-risk individuals.
So what does that mean practically in the procedure room? How does that change what you do?
It means that if you have a difficult cannulation in a high-risk patient and you manage to get a wire into the pancreatic duct during your attempts to access the bile duct, you should strongly consider placing a prophylactic PD stent, even if you've already given the rectal NSAID. The trial provides good evidence to support that combined approach for maximum protection in the highest risk scenarios.
Okay. And just quickly, what about the other adverse events? Any key takeaways on bleeding or cholangitis?
Sure. Post-sphincterotomy bleeding is more likely if the patient is on anticoagulants or antiplatelets that weren't stopped appropriately, usually need about 3 days off for safety. Post-ERCP cholangitis, that severe infection, is a major risk if you inject contrast into obstructed bile ducts but then fail to adequately drain them. That's a critical error to avoid. And finally, there's the ongoing concern about duodenoscope-related infections transmitted between patients despite cleaning. That's really driving the push towards using scopes with disposable components like the tip or even fully single-use duodenoscope.
Okay, now we're getting into the real technical heart of the ERCP. Everything hinges on getting into the right duct, achieving successful, safe biliary access. This really is where technical skill comes to the fore. Hashtag tag techniques for difficult biliary cannulation.
It absolutely is. Failing to cannulate or taking too long trying is not just frustrating. It directly increases the risk of PEP and delays therapy. The benchmarks for expertise are pretty high. Experienced endoscopists should be aiming for successful cannulation in over 98% of all patients, and over 90% even in patients who haven't had previous surgery on their papilla, the so-called native papilla.
And the way we approach initial cannulation has changed, hasn't it? What's considered the standard now?
Yes, the standard approach now is wire-guided cannulation, WGC. Using a guide wire to lead the catheter into the duct has been shown to have a higher success rate and, importantly, a lower risk of PEP compared to the older method of injecting contrast first to see where you are. Generally, having the physician control the wire directly is preferred for those fine, subtle movements needed. But of course, sometimes even standard WGC doesn't work easily, and that's when we get into the territory of difficult cannulation.
Right. So when standard WGC fails, and maybe you keep accidentally going into the pancreatic duct, PD, instead of the bile duct, CBD, you can actually use that PD access to help you.
Right.
What are the main techniques that don't involve cutting the papilla first, the non-pre-cut methods?
The most common one is probably the double guide wire technique. Here, you intentionally place a guide wire into the pancreatic duct and leave it there. Then, using that PD wire as a landmark, you try to cannulate the bile duct right alongside it, typically aiming your device slightly upwards towards the 11 o'clock position relative to the PD wire. But the crucial safety point here, remembering the SVI trial, is that if you use this technique, you must place a prophylactic pancreatic stent at the end of the procedure. Another option is to deliberately place a pancreatic stent first and then try to cannulate the bile duct over or next to that stent.
Okay. Now, if those strategies don't work, then we start thinking about pre-cutting, actually making a cut in the papilla before you've secured deep access into the bile duct. The sources really stress this is for experts only due to higher risks.
Absolutely. That cannot be stressed enough. Pre-cutting definitely carries higher risks of both pancreatitis and perforation, so it should only be attempted by highly experienced therapeutic endoscopists. Now, if you have managed to get access into the pancreatic duct, the perhaps safer pre-cut method is called transpancreatic septotomy. You have a wire deep in the PD for safety. Then you use a special cutting device, like a needle knife or a traction sphincterotomy, to make a controlled cut starting from inside the pancreatic orifice, cutting upwards towards the bile duct, that 11 o'clock direction. The idea is to cut through the septum, dividing the two ducts, essentially unroofing the common channel to expose the biliary opening. And again, because you access the PD, leaving a prophylactic PD stent is mandatory.
What if getting PD access is the problem, or you opt for a needle knife approach directly?
Well, if you're going to use a needle knife, arguably the safest way, if you have PD access, is the needle knife over pancreatic stent technique. You place the PD stent first, which protects the pancreatic opening, and then you use the needle knife to make that cut towards 11 o'clock, similar to the septotomy. If you simply cannot get into the pancreatic duct at all, then the final and probably riskiest option is the needle knife fistulotomy. Here, you basically ignore the papillary orifice itself and make a puncture with the needle knife directly into the bulging roof of the papilla, aiming upwards towards where you expect the bile duct to be, trying to create a new opening, a fistula, directly into the CBD.
Okay, so just to summarize that algorithm for difficult cannulation for the listener, start with standard wire-guided cannulation. If that fails after a reasonable time, try the non-pre-cut techniques like double guide wire. If you get PD access during this, great, place a prophylactic PD stent, and then you can consider the transpancreatic pre-cut methods. If you don't get PD access and non-pre-cut fails, only if you are highly experienced should you consider needle knife techniques, maybe fistulotomy. Otherwise, the safest option is probably to stop, maybe place a temporary PD stent if you accessed it, and refer for alternative access, like EUS-guided drainage. #tagged, interpreting the pancreatic biliary landscape.
Exactly. Now, moving from the how of getting access to the what you see once you're in the image interpretation, this is where the diagnosis happens and where you plan your therapy. The cholangiogram, bile duct picture, and pancreatogram give you that crucial roadmap.
Yeah, the sources provide a great visual checklist of things you absolutely need to be able to recognize. Let's run through some key examples. How do you spot different problems?
Well, you need to distinguish benign from malignant findings. For instance, you need to clearly see a distal common bile duct, CBD stone, versus maybe stones that are impacted higher up, blocking the cystic duct. Critically important is recognizing signs of malignancy. For example, seeing a classic bismuth type 3 hilar stricture, which is a narrowing right at the bifurcation of the main hepatic ducts extending into the branches on one side or the other, that tells you it's likely cholangiocarcinoma and dictates a very specific drainage strategy.
Right. And what about signs of chronic inflammation or disease?
For chronic pancreatitis, you're looking for those classic features in the pancreatic duct. Irregular narrowings, strictures, dilated segments between them, maybe calcified stones within the duct. For biliary disease, you might see the characteristic beating and irregularity of the intrahepatic ducts, that sort of string of pearls appearance, which is typical for conditions like primary sclerosing cholangitis, PSC, or sometimes AIDS cholangiopathy. You also need to spot things like bile leaks, often seen as contrast extravasating near surgical clips after gallbladder surgery, or maybe from an intrahepatic duct after trauma.
And finally, recognizing anatomical variants that can make life difficult.
The most common one by far is pancreativism. You suspect this when you easily cannulate the major papilla, inject contrast, but only see a small, short ventral pancreatic duct draining just the head of the pancreas. The main dorsal duct, draining the body and tail, exits separately through the minor papilla. Recognizing this stops you from dangerously persisting and trying to cannulate a duct that simply isn't connected to the main papilla.
Okay, let's move into some specific advanced therapeutic techniques now, starting with how we tackle those really large, stubborn stones in the bile duct that won't come out easily. #tag sphincteroplasty for large CBD stones.
Right. When you have very large stones, just cutting the sphincter muscle, a sphincterotomy often isn't enough to get them out. So we use a technique called biliary sphincteroplasty. Now, technically, this is defined as dilating the bile duct opening with a balloon after you've already performed at least a partial endoscopic sphincterotomy. It's an alternative to doing a very large sphincterotomy and then using mechanical baskets to crush the stone, and it's considered comparably effective, but sometimes technically easier.
Okay, walk us through the key steps for doing this balloon dilation safely. And importantly, what's the big risk you absolutely have to avoid?
Sure. So after you've done the initial cut, you select your balloon dilator. The size is really important. It needs to be large enough to potentially allow the stone to pass, so typically equal to or slightly larger than the stone diameter, but, and this is crucial, it must not be larger than the diameter of the normal bile duct above the stone, where the duct widens out. You then inflate the balloon slowly under fluoroscopy, watching for the waste in the balloon caused by the stricture to disappear. You usually hold the inflation for 30 to 60 seconds.
And that critical warning about where the stone is.
Yes, this is the absolute danger zone. You must never inflate the balloon when it's right alongside the stone, especially if the stone is impacted in the lower duct. If you inflate the balloon against the stone, the outward force has nowhere to go but sideways, and you can easily perforate or rupture the common bile duct wall. That's a surgical emergency. The dilation has to happen at the level of the papillary orifice itself after the stone has maybe moved up slightly or after the initial cut has created some space.
Makes sense. And beyond just getting the stone out now, this technique actually has a long-term benefit for patients who tend to form stones repeatedly, doesn't it?
It does seem to. Studies have shown that performing sphincteroplasty, compared to just doing a sphincterotomy alone, actually reduces the risk of stones recurring in the bile duct later on. One study showed recurrence over 2 years dropped from about 37% with sphincterotomy alone down to around 21% with sphincteroplasty. So it might offer a more durable result for some patients. # managing malignant hilar strictures.
Okay, now moving to probably one of the most technically challenging and high-stakes areas in ERCP, dealing with malignant blockages right up at the hilum of the liver where the main bile ducts join.
Yeah.
We use the Bismuth-Corlett classification to describe these strictures, right?
That's right. The Bismuth classification just tells us where the stricture is and how far it extends. Type 1 is below the bifurcation in the common hepatic duct. Type 2 involves the bifurcation itself. Types 3A and 3B involve the bifurcation and extend into the secondary branches on the right, 3A or left 3B side. And type 4 is multicentric or involves secondary branches on both sides. Knowing the type is critical because it dictates how you approach drainage.
And for patients where the cancer is unresectable, the goal of stenting isn't necessarily to drain the whole liver, is it? There's a specific volume target.
Exactly. This is a really important concept in modern palliative biliary stenting. The goal is to effectively drain more than 50% of the functional non-atrophic liver volume. For a simple type 1 stricture below the bifurcation, a single stent is usually enough. But for the more complex types 2, 3, and 4 ideally, you might want to place stents bilaterally, draining both the right and left systems. However, that can be technically very difficult. So the principle is that even placing a single stent into one side, say the right system, can be adequate if that side represents more than 50% of the healthy liver volume.
Okay, now we need to hammer home the single most dangerous mistake you can make when dealing with these hilar strictures, something that can lead to disaster.
Yes. This is probably the cardinal sin of hilar stenting. You must never inject contrast medium into biliary ducts that you do not intend to immediately stent and drain. If you fill up ducts with contrast, especially if they're obstructed, you're essentially creating a stagnant pool of contrast and bile, which is a perfect breeding ground for bacteria.
And the consequence if you opacify a lobe but don't drain it.
The consequence is often catastrophic, potentially fatal, post-ERCP cholangitis and sepsis. If you accidentally fill a segment you realize you can't cannulate or stent, you need to be extremely aggressive with broad-spectrum antibiotics immediately to try and prevent that infection from taking hold. It's a situation you absolutely want to avoid by planning your contrast injections very carefully based on where you intend to place stents.
All right, let's touch on cholangioscopy, actually putting a tiny camera inside the bile duct to see directly.
Right, cholangioscopy gives you that direct visualization. The most common systems now use a digital single-operator cholangioscope, or SPY-JUAS, which is basically a very thin 10 French scope that goes through the main duodenoscope. It has two main roles. First, it's invaluable for treating really large or difficult bile duct stones using fragmentation techniques like electrohydraulic lithotripsy, EHL, or laser lithotripsy under direct view. Second, it allows you to visually inspect indeterminate strictures, ones where you're not sure if they're benign or malignant, and take targeted biopsies right from the suspicious area, which significantly improves diagnostic accuracy compared to just brushings or random biopsies.
And how does that EHL, the electrohydraulic lithotripsy, actually work to break up stones?
EHL works by creating miniature shockwaves. There's a special probe that delivers a tiny electric spark at its tip. Critically, this has to be done in a fluid environment of saline, not sterile water, because you need the conductivity. The spark rapidly vaporizes the saline at the tip, creating a tiny steam bubble that expands and collapses violently, generating a powerful shockwave. You position the probe right against the stone, fire these sparks repeatedly, and the shockwaves literally fragment the stone into smaller pieces that can then be removed with baskets or balloons.
Okay, let's broaden the view now and look at some other advanced endoscopic applications, maybe starting with stenting in different parts of the GI tract, hashtag endoluminal stenting across the GI tract.
Sure, stenting strategy really depends on where you are and what you're trying. Achieve temporary relief versus long-term palliation. Let's start with esophageal stenting. We typically use self-expandable metal stents, or SEMs. If the goal is temporary, like bridging to surgery, or maybe sealing a benign fistula like a tracheoesophageal fistula, you generally prefer a fully covered SEMs because they don't embed into the tissue as much and are easier to remove later.
And if it's for a malignant stricture that's not going away.
For long-term palliation of malignant esophageal strictures, you often prefer partially covered or even uncovered SEMs. The uncovered ends allow the stent to embed into the tumor tissue, which significantly reduces the risk of the stent migrating or slipping out of place. Migration is the biggest problem with fully covered esophageal stents. If you do use a fully covered stent, especially near the GE junction, you often need to anchor it with endoscopic sutures or clips to prevent it from migrating downwards. And patients definitely need high-dose PPIs if the stent crosses the GE junction to prevent reflux esophagitis around the stent.
Right. And diet is crucial after esophageal stenting, isn't it?
Absolutely critical. The stent provides a passage, but it can still get blocked. Patients need really clear instructions. Food must be soft, almost pureed consistency, moist, and chewed incredibly thoroughly. No big chunks of meat or dry bread. Otherwise, you risk a food bolus impaction within the stent, which is a major problem.
Okay, moving down to the duodenum.
Yeah.
When do we stent there, and how does it stack up against surgery?
Duodenal stenting is almost always for malignant gastric outlet obstruction cancer, blocking the exit of the stomach or the first part of the duodenum. It provides good palliation of nausea and vomiting. However, it's generally reserved for patients with a relatively limited life expectancy. If a patient with malignant obstruction is expected to live longer than, say, 3 to 6 months, then surgical bypass of gastrojejunostomy is often considered the better long-term option, as stents can eventually occlude or migrate. When placing a duodenal stent, you typically want it to extend from just before the pylorus well into the duodenum, past the obstruction, but ideally before reaching the ampulla if possible.
Got it. And finally, colonic stenting. What are the main roles there?
Colonic stenting really serves two main purposes. First, like elsewhere, it can provide palliation for patients with incurable obstructing colon cancer. But second, and this is increasingly common, it can be used as a bridge to surgery in patients with potentially curable malignant obstruction. Placing a stent relieves the acute obstruction, allows the patient's condition to be optimized, maybe allows for bowel prep, and converts an emergency surgery into a safer planned elective operation, often allowing for a single-stage resection without needing a colostomy.
Now, there's a really important specific drug interaction warning related to colonic stenting that we absolutely have to mention.
Yes, this is vital for patient safety. Colonic stenting should generally be considered contraindicated in patients who are actively receiving bevacizumab Avastin or other similar anti-angiogenic therapies. These drugs impair blood vessel formation and wound healing, and there's a significantly increased risk of delayed colonic perforation after stent placement in patients taking them. It's a known serious complication. Hashtag endoscopic ultrasound, EUS, for submucosal lesions.
Okay, let's switch gears to endoscopic ultrasound, or EUS. This gives us that amazing view beneath the surface lining. It all starts with recognizing the wall layers, right?
Exactly. Standard EUS shows the GI wall as 5 distinct layers, alternating bright, hyperachoic white, and dark, hypoechoic black. For identifying where a submucosal lesion is coming from, the key layers to focus on are the interface echoes and the main layers. The first layer, white, is the superficial mucosa interface. The second, dark, is deep mucosa. The third, white, is the submucosa. The fourth, dark, is the muscularis propria, the main muscle layer. And the fifth, white, is the serosa or adventitia interface. Knowing which layer a lesion arises from is the first step in figuring out what it might be.
So how do we use that layer information, plus how the lesion looks on ultrasound, its echogenicity, to differentiate the common types of submucosal lumps and bumps?
Okay, let's take the most common ones. A gastrointestinal stromal tumor, GIST, which is the most important one to identify, typically appears as a hypoechoic dark mass, and it usually arises from either the second layer, deep mucosa, or more commonly the fourth layer, muscularis propria. A lipoma, which is just benign fatty tissue, characteristically originates in the third layer, submucosa, and is distinctly hyperechoic, bright white. Lipomas often also have that positive pillow sign. On regular endoscopy, they indent softly when you push on them with forceps. And another common one, aberrant pancreas, pancreatic tissue that ended up in the stomach wall during development, usually appears as a mixed or heterogeneous echogenicity lesion, also in the third submucosal layer, and you can sometimes even see a tiny anechoic black ductal structure within it. Hashtag detachable snares, endoloops.
All right, let's talk about a useful gadget for preventing complications during polypectomy. The detachable snare, or endoloop. What's its main job?
The primary evidence-based role for endoloops is to prevent post-polypectomy bleeding, specifically delayed bleeding. They are most strongly recommended for removing large pedunculated polyps. That is, polyps on a stalk where the head of the polyp is big, say 20 millimeters or more, and the stalk itself is relatively thick, maybe 5 millimeters or more. Putting a loop around the base of that stalk before cutting can significantly reduce bleeding risk.
And using it requires pretty careful technique to make sure it actually works, right?
It does. You carefully position the open loop around the base of the polyp stalk, as close to the bowel wall as possible without catching the wall itself. Then you tighten it down firmly. Once you deploy the loop, click it off the delivery system, it's closed permanently, you can't reopen it. The crucial step then is when you resect the polyp using your electrocautery snare. You must position the cutting snare above the deployed endoloop, typically about 3 to 5 millimeters up the stalk towards the polyp head. You cut there. This ensures the heat from the cautery doesn't damage the loop, and more importantly, it leaves a small cuff of tissue above the loop, preventing a loop from just slipping off the cauterized stump after the polyp is removed.
Okay, let's wrap up with two very distinct clinical situations that require their own specific protocols, often involving urgent decisions. Hashtag managing ingested foreign bodies.
Right, dealing with ingested foreign bodies is all about rapid triage. You have to quickly decide, is this an emergency needing immediate removal, or is it urgent but can wait a bit, or can it just be observed?
So what constitutes a true emergency? What needs to come out within, say, 2 to 6 hours?
The absolute emergencies are any foreign body causing complete esophageal obstruction, meaning the patient can't even swallow their own saliva. Any impacted sharp-pointed object in the esophagus because of the high risk of perforation, and any disc battery lodged in the esophagus due to the risk of rapid liquefaction, necrosis, and perforation. Those need removal ASAP. Other foreign bodies stuck in the esophagus, if they're not sharp and not causing complete obstruction, can usually be managed urgently within 24 hours. And many small, blunt objects that have made it down into the stomach, especially if they're less than about 2.5 centimeters, can often just be observed to see if they pass on their own.
Now, what's the one situation involving foreign body ingestion where endoscopy is absolutely not the answer?
This is critical. Ingestion of illicit drug packets, usually cocaine or heroin wrapped in latex or plastic. Endoscopy is strictly contraindicated in this scenario. The risk of accidentally rupturing a packet during the procedure is just too high, and that would lead to massive, likely fatal drug overdose. Management here is supportive care, observation for signs of packet rupture or obstruction, and immediate surgical consultation if problems arise.
Okay. And when you do go ahead with endoscopic retrieval, especially for sharp things, you need protective devices, right?
Yes, absolutely. To protect the patient's esophagus and particularly their hyperpharynx and airway during withdrawal, especially with sharp objects like open safety pins or bones, you should use a protective device. The most common are esophageal overtubes, basically a plastic tube you slide down alongside the scope, or sometimes a soft rubber hood fitted onto the tip of the endoscope. These shield the sharp object as you pull it back up, preventing mucosal injury and also helping you maintain access if you need to make multiple attempts. Hashtag endoscopy in the bariatric surgery patient.
All right, finally, let's talk about endoscopy in patients who've had bariatric surgery. The sources really stress that knowing the patient's specific altered anatomy is job number one, particularly the most common one, the Roux-en-Y gastric bypass, or RYGB.
Absolutely. Before you even scope a bariatric patient, you need to know what operation they had. With an RYGB, you're dealing with a very small gastric pouch and an anastomosis connection between that pouch and the small bowel, the gastrojejunal or GJ anastomosis. And then further down, another anastomosis where the bypass loop of bowel connects back in the jejunal or JJ anastomosis. The key thing for the endoscopist is that usually you can only reach and examine the gastric pouch and the GJ anastomosis with the standard scope. That distal JJ anastomosis is typically way too far down to see. Most of the early and late complications we manage endoscopically occur at or near that GJ anastomosis.
Okay, so let's talk about early complications first. What about leaks from the anastomosis?
Anastomotic leaks usually show up within the first week or two after surgery, often presenting dramatically with tachycardia, pain, fever signs of sepsis. While the standard management is often surgical re-exploration and repair, endoscopy can play a role. For some small, contained leaks diagnosed early, it's sometimes possible to manage them endoscopically using things like over-the-scope clips, OTSC, or covered stents, but surgery is often still required.
Right. And another common early-ish issue is narrowing or stricture at that GJ anastomosis. That requires dilation, but there's a specific target size you're aiming for, isn't there?
Yes, anastomotic strictures are quite common and cause trouble swallowing. They can usually be safely dilated endoscopically with balloons, but the key is to do it gradually, often over multiple sessions. And you want to aim for a final diameter of around 12 millimeters. You specifically want to avoid dilating much beyond 15 millimeters. If you make the opening too wide, you essentially defeat the restrictive purpose of the gastric pouch, which can lead to loss of restriction and eventual weight regain long term. So gentle, stepwise dilation to about 12 millimeters is the goal.
Okay. What about late complications? Things like marginal ulcers.
Marginal ulcers are ulcers that form right at or just downstream from the GJ anastomosis in the jejunal tissue, which isn't used to stomach acid. The main causes are smoking, H. pylori infection, which should always be checked for and treated, and NSAID use, which should be strictly avoided after ROAGB. Treatment involves high-dose PPIs, and the sources mention that opening the PPI capsule and sprinkling the granules might help with absorption and healing, plus stopping smoking and NSAIs and treating H. pylori if present.
And finally, a really crucial area, nutritional deficiencies, especially the potentially catastrophic one involving thiamine.
Yes, nutritional deficiencies are a major long-term concern after bariatric surgery, especially malabsorptive procedures like ROAGB. Patients can become deficient in iron, B12, calcium, vitamin D, folate, and others. But the one that can present as an emergency is thiamine, vitamin B1 deficiency. This should be suspected in any post-bariatric patient who develops persistent, intractable nausea and vomiting, especially if they also have neurological symptoms like confusion, ataxia, unsteady gait, or eye movement problems, Wernicke's encephalopathy. And here's the absolute life-saving protocol. If you suspect thiamine deficiency, you must give thiamine intravenously before you give any glucose-containing fluids or nutrition. Giving glucose first can actually precipitate or acutely worsen Wernicke's encephalopathy in someone who is thiamine depleted. Thiamine first, then glucose. Non-negotiable. #tag outro.
Wow. That was a genuine deep dive. We've covered a huge amount, really showing how clinical success in advanced endoscopy demands balancing that foundational safety, things like ergonomics, to protect the physician, strict adherence to LR for radiation with really high-level technical skill and strategic thinking.
Absolutely. I think what really comes through is that expertise here isn't just about fancy scope maneuvers. It's about connecting the dots, knowing why the SVI trial changed your approach to PD stenting, understanding exactly why that 50% liver volume drainage rule is critical for hilar cholangiocarcinoma, or remembering the precise placement for a return electrode in a pregnant patient. It's all interconnected, meticulous planning based on evidence and safety principles.
And that focus on planning and integrating new knowledge brings us to our final provocative thought for you, the listener. The source material, and just the field in general, clearly shows technology accelerating rapidly. We have disposable scopes emerging to combat infection risk, US-guided techniques offering entirely new ways to access the biliary system, bypassing the papilla altogether. So we're moving towards a future where maybe procedural decisions become less about pure manual dexterity at the papilla and more about sophisticated planning and leveraging these less invasive technologies. The question to ponder is, how quickly will these advanced alternatives like EUS-guided drainage start to truly displace the traditional high-risk access techniques we discuss, things like needle-knife pre-cut, especially in the most complex cases? Are we heading towards a future where manual mastery becomes secondary to technological and strategic integration? Something to think about.
Definitely something to watch. We'll see you on the next deep dive.